Hello. So very good evening and to you, sir, good morning. From NNF Kerala, Indian Academy of Pediatrics and IAP NeoChap. It's a part and parcel of Indian Academy of Pediatrics focusing on neonatology. So I welcome each and every one of you to the Learn from Legend series, in which we have a legendary today, none other than Professor Collegial Gautam, Chair of Pediatrics and Pediatrician-in-Chief, Memos Children's Hospital, Orlando, Florida, USA. He will speak to us on the burnout and resilience in healthcare. I think it's a very relevant topic in the specialty because, as you all know, most of the neonatologists are very often stressed out and they spend hours together in the NICU caring for the high-risk neonates. So it will be a learning process for us tonight to hear from him about the experiences abroad, and we can connect it to our setup as well. To moderate the session, we have two eminent neonatologists of India, Dr. Devjani Gupta, Senior Consultant Neonatologist, Narayana Hospital, Howrah, Zenith Super Specialist Hospital, Kolkata.
Good evening. Good evening all.
Good
you. Thank you for the invite. Good evening all.
And Dr. Prakash A, Professor and Head Neonatology, Sri Ramchandra Medical College and Research Institute, Chennai. Welcome to you, sir.
Thank you. Thank you very much.
Thank you very much. Thank you.
So,
thanks for the invite.
Let's start the proceedings. Over to Manoj.
Hello, everyone. Warm greetings to the 35th session of Learn from the Legends. We have today a great legend whom I would personally call a savior in a moment of crisis. We were supposed to have, as you might be aware, the scheduled talk by Professor Boris Kramer on ventilation strategies in extreme preterm neonates today. And however, due to some unforeseen medical emergency, Professor Kramer had to excuse himself, and on that too yesterday, the 11th hour. Because of no fault of him, actually it's so nice of him to actually explain at the time when he had to somehow leave. And then we had the savior in the form of Professor Gautam Suresh. Professor Gautam is a neonatologist who did his MD and DM from PGH Chandigarh and also trained in Australia and in US in Vermont. He has a master's degree in quality improvement and as a postgraduate was a postgraduate fellow at the Vermont Orford Network. Until recently, he was the chief of neonatology at Texas Children's Hospital in Houston, Texas, and is now the chair of pediatrics at Nemo's Children's Hospital in Orlando, Florida. We all know, he is the editor of the well-known textbook Assisted Ventilation of the Neonate, and he is an expert in quality, safety, and evidence-based medicine and has published numerous articles and book chapters. those of you who have been following the series right from beginning, Professor Gautam was kind enough to give us a lecture last year in December on the again another topic, quality improvement initiative, the various aspects related to that, and we all thoroughly enjoyed that lecture. Now we come to another relevant problem, the burnout, and how do we get out of this. So that is going to be the talk today. So without prolonging his bio sketch, let me once again welcome the legend we have all been looking forward to hear again and again, Professor Gautam Suresh. Over to you, sir.
Can you see my slide, Manoj?
Yes, sir. We can hear you also.
Good evening, good afternoon, good morning to people in various parts of the world. It is my pleasure to be here today talking to all of you about a topic close to my heart. Manoj contacted me yesterday saying that they needed a speaker for today, and I immediately said yes, because A, I love to teach, and B, I think the topic of today's conversation is of extreme importance that needs to be discussed and highlighted and addressed. I hope you will enjoy the talk. Unfortunately, we'll have to wrap up exactly at 1 hour, but I will be available later on with if you have any questions or comments. So let's start. I don't have any conflicts of interest to disclose. And I always like to start my talks by acknowledging my teachers back from medical school onwards, from whom I have learned so much. So I'm grateful to all of them for their mentorship and guidance and teaching. Let's start by understanding the terminology and the definitions of terms like burnout and resilience. Burnout, which was first described by a researcher called Christina Maslach many, many years ago, is a work-related syndrome involving emotional exhaustion, depersonalization, and a sense of low personal accomplishment. It usually occurs in individuals without a history of psychological or psychiatric disorders. That means it's mostly a work-related syndrome and is not an internal mental health problem. The standard way of identifying burnout is the Maslach Burnout Inventory, which has 22 questions in 3 domains: emotional exhaustion, depersonalization, and lack of personal accomplishment. And the questions ask you, how often do you have symptoms related to these domains? And the more frequent and the more severe the symptoms, the higher your likelihood of burnout is. Here are the questions in the emotional exhaustion domain. I won't read all of them, but I'm sure all of us have experienced these symptoms at the end of a difficult workday. Similarly, here are questions about depersonalization, and this is one of the characteristic domains of burnout, where you start treating colleagues and patients like objects instead of human beings. So you become more callous towards them. And finally, a sense of low personal accomplishment. These are the questions in that domain. And at the end of the day or at the end of your career, you want to feel like you have contributed and accomplished something as a physician or a health professional. And people who are burnt out have a sense of low personal accomplishment where they don't enjoy working and they feel that they're not contributing much to their job. So these are the 3 domains of burnout: emotional exhaustion, depersonalization, and low personal accomplishment. Now, the Maslach inventory has 22 questions, so it takes a long time to respond to. And that, in turn, causes a reduction in survey response rates when you send out the survey. People have therefore explored shorter instruments. Some of them contain only 1, 2, or 3 items, And there are other inventories that people have developed. The one at the bottom, the Physician Wellbeing Index, is a short, I think it has 8 questions. It's a short tool developed by the Mayo Clinic in Rochester, Minnesota. And that is becoming popular as a way of identifying and measuring burnout in organizations. But if you're doing a research study, or if you really want to get a rigorous assessment of the prevalence of burnout, the Maslach Burnout Inventory is the way to go. So now that we have understood the terminology and how to measure burnout, let us see how common burnout is and why it has become such a hot topic of discussion. The investigators from the Mayo Clinic have been some of the leading researchers in this area for almost 20 years. And they published a paper in 2015 where they reported data from a large sample of physicians. These are all specialties, not just pediatrics or neonatology, in the US. And they compared data on this survey from 2011 to 2014. The data from 2011 is in orange, and the data from 2014 is in blue. And if you just look at the bars, you can see that the prevalence of physicians reporting burnout ranges anywhere from 40% to 75%. And this was pre-COVID, remember. So in the US, there are a lot of data to report that 50 to 70% of physicians feel burnt out, which is an alarming situation. And you can see also in this graph that between 2011 and 14, the numbers got worse. And the other important point in this graph is different specialties are at different risks of burnout. And in general, the specialties that deal more with death and morbidity and intensive care, emergency medicine, high stakes specialties, physicians in those realms are more at risk for burnout than in some other specialties. There are many other studies of this nature, and this is a table summarizing the prevalence of burnout in different studies and the subjects in those studies. I'm not going to read it through it line by line, but again, you can see that the numbers are pretty high, and most of them report numbers around 40 to 50% burnout rates. Again, so that's an alarmingly high prevalence rate of burnout. What about the situation in India? Kesarwani and colleagues just last year published a paper. This came out in March 2020, where they reviewed data from 15 studies of healthcare professionals in India. These were all healthcare professionals, not just physicians. And they found that if you look at emotional exhaustion, the meta-analysis of the data from the studies show a 24% prevalence of emotional exhaustion and a 27% prevalence of depersonalization. These are the numbers at the bottom right of the corner, summarized by the diamond in the meta-analysis. I'm sure all of you are familiar with the forest plots. So again, even in India, prevalence was around 25% in these studies, but I think frankly that this is an underestimate. And besides, these numbers were pre-COVID because their search only went up to October 2019. I bet you the numbers are much higher in India today. So because of the alarmingly high prevalence of burnout in many, many studies, burnout has been called an epidemic, a threat to our profession, a public health crisis, and a hidden healthcare crisis, and an under-recognized threat to safe, high-quality care. So a lot of organizations, including the National Academies of Medicine in the US, the American Medical Association, many professional societies have all published statements saying that this is a problem and we need to do something about it. So these are the societies that have proclaimed the importance of this topic and the need to address it. So one thing before we proceed any further is to really be clear that burnout is a work-related syndrome. There are non-work related causes of lack of wellness, for example, mental depression or other mental health problems, substance abuse. Many health professionals go through life stressors. So all these can cause you to feel a lack of wellness as well. And there may be overlap between these two entities, but we have to realize that burnout and its solutions are largely related to the work environment and the nature of the work. What are the effects of burnout and why should we care? There are potential effects on health professionals themselves. For example, burnt out health professionals are prone to disruptive behavior. They may erupt in anger, or they may be nasty or mean to their colleagues or to patients. They are prone to injury to themselves, including traffic accidents, even after adjusting for confounding factors like fatigue. It can lead to mental health problems. Suicide rates in physicians are much higher than the general population. Burnt out health professionals can have relationship problems and even divorce. And there are a lot of personal biological health risks like decreased immunity, increased inflammation, elevated cardiovascular risk, and overall shorter lifespan that burnout can lead to. Burnout can also cause effects on patient care. It's been described in multiple studies that physicians and health professionals who are burnt out are more prone to be involved in medical errors. There can be an increase in healthcare associated infections. There can be worse communication and empathy with patients because you don't feel really compassionate and humanistic if you're feeling burnt out yourself. And this is a quote from a poet, Mark Nepo. One of the mysteries of illness is that no one can be healed by anyone whose emptiness is greater than their own. So if your own tank of compassion and empathy and understanding and kindness is empty, you cannot take care of others in a compassionate way. Perhaps the most important and underemphasized aspect of burnout is its effect on organizations. Burnout can lead to decreased efficiency and productivity, increased turnover, increased costs, and health professional wellness is vital for high quality care. If an organization wants to deliver results, they need to have staff who are thriving. And there are a lot of experts who have called for a routine measurement of health professional wellness in organizations. Now, let us move on to the more practical aspects of the talk, where we will discuss the causes and the prevention and some solutions for burnout and how to promote resilience. I want to offer to you a model in which to think about burnout and resilience. All of us as health professionals exist in a triangular relationship between ourselves, our colleagues, and patients. And the three of us in this triangle are surrounded by this circle called the workplace. So the causes and solutions of burnout rest in these four elements of the framework: yourself, your colleagues, patients, and the workplace. Let's talk a little bit about the workplace and what factors there can contribute or mitigate burnout. The most important factor is your workload and the resources provided to do the work. So many health professionals all over the world work under very suboptimal conditions. They have excessive workloads, they don't have enough resources, they can't find their equipment or the supplies that they need to get the job done easily. And it's a very inefficient workplace. So that often leads to burnout or contributes to burnout, and improving efficiency and what's known as the pebble in your shoe phenomena at work it's a very important way of addressing burnout. In the US and many other places, the electronic medical record is one of the major contributors to burnout. And in the US, many physicians finish up their day's work and then they go home, they log in, and they complete their notes or check their patients' labs or respond to queries from patients after dinner, after putting their kids to bed. So that is known as pajama time or the work after the work. And this is work that they're doing that is not compensated in their salary. It's extra work. So the EMR has consistently come out in many studies as one of the major culprits of burnout. Unfortunately, in my field of quality and safety, there are many demands that we place on health professionals, like do this, comply with this guideline, follow this policy, clean your hands and scrub the hub, and make sure you check everything before you give a medication. And it seems like physicians are barraged with all these quality improvement initiatives, and that also leads them to just get worn out by quality improvement overload. If the organization has confidential programs and employee assistance programs to help physicians and health professionals deal with their psychological challenges and demands of the work, that helps a lot. And organizations should also have good disruptive behavior policies where they will not tolerate unprofessional or disruptive behavior by their staff. And finally, organizations should also have good disciplinary action when there is a person whose behavior continues to be bad in spite of coaching and feedback. Then they need to be removed from the organization. And if these things are not done, it just degrades the morale of the staff and promotes burnout. There are also some important intangible factors within organizations. The commitment and support from leaders has come out as one of the major variables and factors that can mitigate or cause burnout. And I'm fond of saying that every leader, whether you're a consultant in a ward round or a leader of a neonatal resuscitation, or you're running a code, or if you're a manager or the chief executive officer, you're a CEO. And CEO in this case means chief emotional officer. So any person who has a leadership role in any capacity should address the emotions of the people that they're managing and leading. Another important intangible factor is the congruence between your values internally and the expectations from the organization. So if a person works in an organization where all the right things are said by the leaders and executives, but their actions don't follow through, and there's a disconnect between what they say and what they're expecting the doctors to do, then doctors who have internally different set of values that are altruistic, they want to do the right thing and help patients, can feel a profound sense of dissonance between what's being said and what's being done. And that also is a draining on a person's psyche. Asymmetric rewards are very, very common. It refers to the phenomenon where if a person does something wrong or makes a mistake, people are quick to point that out and punish them and blame them and shame them. But when they do something properly and when they do it well, very rarely do they get compliments and acknowledgement of a good job done. And finally, one of the most important intangible factors is psychological safety, which means an atmosphere and a culture where a person feels safe in speaking up and pointing out risks and hazards and problems without fear of intimidation or retaliation. Of course, all these phenomena have been exaggerated with COVID, and Schwartz and colleagues last year published a nice article describing the needs of clinicians during the COVID-19 pandemic. They're listed on this slide, and they include basic things like providing rest and clean housing and protective equipment, a specialized training for pandemic-related job changes. So if you're expected to go take off adults, then you need to be provided training and orientation on how to do that. Recognition and clear communication from leaders. Acknowledgement that the whole pandemic and being on the front lines of healthcare has been very, very distressing to everybody. Peer and social support interventions, mental health support interventions, and resilience and stress reduction training are very, very important. And in my previous role as chief, I paid a lot of attention to supporting the staff psychologically during the pandemic. We had daily Zoom calls where we would get together as a community, share our vulnerabilities and fears and distress. And sometimes we would have prayer, and every day we would have a poem that we read. And it was a profound way of connecting people. I also organized meditation sessions for our staff every day. And so addressing the emotional needs during the pandemic has been very, very crucial to preventing and mitigating burnout. So that was a little bit about the workplace, the circle around the triangle. Now let's talk a little bit about our colleagues and how we can be good colleagues to others. One thing we can do is be very generous with our compliments. I mentioned the concept of asymmetric rewards. So please reach out and compliment your colleagues or your students or your postgraduates or trainees. Whenever they do something well, don't just be quick to criticize them when they do something wrong. When there's a critical incident such as a death or a code or an unanticipated event in your unit, you should get in the habit of doing debriefings, because that really helps prevent the PTSD that people experience after a critical incident. Coaching and mentoring of individuals is very, very important, as is conflict management. And ideally, every organization should have community building activities. Colin West and colleagues from the Mayo Clinic did a randomized trial called the Compass Groups, where they got together groups of physicians every week during lunchtime and had discussions about burnout, professional satisfaction, how to deal with difficult patients, work-life balance, and things like that. And in the randomized trial, physicians who participated in these groups had much better scores on the burnout inventory than the control group. In our section of neonatology at Texas Children's Hospital, before COVID, we used to have story hour where once a month we would get together as a group of colleagues and share stories, and any stories, our personal life, something that happened on a vacation, or your memories of your grandparent. It was a very powerful session which really helped us understand each other as human beings, not just as professional colleagues. Collaboration and working in teams is very important because human beings need to feel a sense of belonging and connection with others in order to be happy and feel safe. And finally, civility, courtesy, and caring for each other goes a long way. And simple things like saying good morning, introducing yourself when you meet other people, saying thank you, or letting other people go in front of you. Simple things like that go a long way in kind of lubricating the social interactions between colleagues. Now let's move on now to the third, so the second aspect of the triangle, which is self. There are many problems with how health professionals, especially physicians, take care of themselves. We are known to be terrible at self-care, and we don't recognize our problems as physicians, psychological problems, and we are very reluctant to seek help. We are also prone to many traits known as physician personality traits. We are subject to perfectionism, conscientiousness, altruism, and compartmentalization of problems. And we tend to sort of try and manage our own problems ourselves and be tough and be stoic and tough it out. But that can only go so far in compensating for a difficult situation. We are prone to what psychologists call cognitive errors or schemata. Unfortunately, we don't have time to go into those. Then when we are involved in a medical error as health professionals, we too can be traumatized. The first victim is the patient, but the second victim is the health professional involved in a medical error. And finally, in specialties like neonatology, we are constantly facing ethical dilemmas and moral distress about end-of-life care or decisions about who to treat, not to treat, how to allocate resources, and all that can add up and drain your emotional battery. But I want to emphasize that a generic approach to understanding the causes of burnout and developing solutions will not work for everybody. There's a famous quotation from Leo Tolstoy in Anna Karenina. All happy families are alike. Each unhappy family is unhappy in its own way. And this applies very well to burnout. The causes of every health professional's burnout and the solutions and the mitigation strategies may be different for different people and in different settings. So there are some things that will work universally, but in other situations, we have to be cognizant about the need to customize the solutions to the setting and the provider so that we don't miss the true causes. So this is what I call as a precision wellness. Just like you have precision medicine, we need precision wellness. One of the first rules of self-care is put on your own mask first. Just like they tell you in the airlines when you're flying, if there's a drop in cabin pressure and the mask drops, put on your own mask first, because if you don't take of yourself, you cannot take care of the person sitting next to you. Same thing in medicine. We have to take care of our own health and mental well-being before we can take care of colleagues and patients. So I offer to you an acronym called Somersets, which is an acronym of items that contribute to self-care. Some of these are more evidence-based than others, and some of them is just common sense and my opinion. First thing is seek help. If you're feeling distressed and if you're not feeling fully satisfied or feeling a sense of burnout, seek out help from a qualified professional or a close friend or a family member that you trust. Make sure to have some time for yourself every day, own time, where you have time to exercise or relax or meditate or just reflect and think, so you unwind during the time. Meditation is one of the most powerful techniques for self-care. I just completed a 10-day silent meditation Vipassana retreat here in the US, and I found it tremendously transformative. And before that, for many years, I have been doing mindfulness meditation, which I have found really helpful. Expressive writing is a technique developed by an expert called Penny Baker in Austin, Texas, where people are encouraged to write about traumatic experiences. And you can Google that term and read about expressive writing. That again is a very powerful solution to mitigating distress. Having strong relationships with family members and friends and colleagues is very important. And basic things like sleeping, eating well, exercising, managing your time well, especially by saying no and not taking on too many things, and minimizing your use of screens and smartphones are all good strategies for self-care. And with sleep, I think I want to emphasize the importance of looking for sleep apnea and treating it if you have it is very, very important. It's a very common disorder, and we need to get investigated for it if you have symptoms. In general, taking an optimistic and a positive view that there is hope and optimism and things can improve and we can accomplish things if we're determined and work hard and work the right way is helpful. And I mentioned mindfulness. There are a lot of articles exploring the promise of mindfulness as medicine. A lot of research has been done on patients and mindfulness, but research is now coming out on the use of mindfulness for health professionals. This is a big interest of mine. People talk about work-life balance, and generally when people talk about work-life balance, you're trading off life versus work. So if you work more, you have less life. And if you work less, you have more life. But there is this concept called the 3 marriages from a poem by David White, I believe, is the poet, which was written about in an article in 2011 by Ludwig. And building on that poem called The Three Marriages, Ludwig emphasizes that all of us live in three marriages. One is to our spouse and family, one is to our work, and one is to ourselves. So all these three marriages have to exist together in harmony, and they should not compete for attention, resources, or space. So we have to find a way of integrating these three marriages. And this is a better concept of work-life balance than this balance approach, where there are trade-offs, where you have more of one thing and less of the other. I mentioned that physicians are notoriously bad at recognizing when they're in trouble. To fix that, the investigators at the Mayo Clinic have developed this well-being index, where you periodically answer questions on a survey, and it shows you where you are in different domains of burnout. So this kind of metric may give you a better insight into where you are as a health professional in your status with burnout and resilience. So in the last few minutes of my talk, I want to leave time for questions. I want to reframe the entire discussion on burnout. We have been talking about burnout and stress, and those are negative things. They're like disease. But if you remember the World Health Organization definition of health, it emphasizes that health is not merely the absence of disease, but a positive state of experience and living, mentally, physically, and socially, if I remember the definition correctly. So what I feel we need to strive for as health professionals, and what leaders need to emphasize and strive for in their organizations, is a positive state, which can be described as a joy in work, a state of flow, which is a feeling of complete immersion in what you're doing, resilience, or eudaimonia, or well-being or flourishing. Eudaimonia is a Greek term that basically means flourishing. And these positive concepts have been emphasized by national organizations in the US as well. And restoration of joy and meaning in work is an important aspect of improving healthcare. Martin Seligman, who is the founder of a field called positive psychology, also emphasizes well-being and 5 elements as crucial to well-being. And he calls it PERMA, P-E-R-M-A, but I rearranged it to say prema, which means love in Indian languages. And prema stands for positive emotion, relationships, engagement, or the feeling of being lost in a task, meaning, and accomplishment. So ultimately, we need to strive to achieve these 5 elements as part of our work, so that we feel fully actualized in our job and our career and our role as health professionals. So I will stop there, and here are some good resources for you to read. I have hundreds more articles that I could share, and feel free to email me with any questions, and look forward to the discussion now. Let me stop sharing my screen now. I'll leave this up for a minute.
Thank you. Thank you so much. It was a fantastic session, and in fact, most of us, we agree, but agree to this, the concept of getting burnt out. I think, including even the consultant level, as you rightly said, especially the leaders. Leaders means that leader at that point of time. Probably even a assistant who comes to manage a baby actually is also a leader at that point of time. So many of us act as leader at different circumstances. And it does, I think everybody, does feel a lot of stress. And in fact, some of the times when I was a junior person working, when I have to manage, and when I look forward and my chief comes in, you get so relieved, at that point of time. Actually, I feel that was one of the important, issue, important element which should be there in your workplace, in relation to tackling the pressure. So we have a few questions on the question answer box. Now, Dr. Lakshmikant Deshmukh has asked how to address mental health issues in organization without formal employee assistance or mechanisms thereof.
So, if I understand the question correctly, we're talking about leaders trying to identify mental health issues. Is that correct?
Yes.
Yeah.
If
So
there is no assistance to seek when there are mental health issues, now how do we tackle it? That's what I understand the question to be.
yeah. So let us suppose that you have a leadership role, and you suspect that somebody may be having some mental health issues, or you're a colleague and you suspect that a colleague or a trainee is having some mental health issues. One of the things we cannot do in the US, according to human resources policies, is we cannot diagnose them and say, it sounds like you're suffering from bipolar disorder. You should go see a psychiatrist. You should not say that. Okay, but you can say things like, I noticed that you appeared very tearful when you heard about that thing. So I think it would be helpful if you go see a qualified counselor or a professional. Now, the question addresses the lack of resources for mental health support. That's a big problem even in the US, especially for children. There's a huge shortage of mental health professionals. And we somehow need to find a solution for that. One solution that has popped up that is helping is telemedicine. And there are a lot of therapists now who do consultations by Zoom. And those consultations can be pretty effective. And there's now even an app and a company that is functioning like Uber or Ola, where you can log in and find a therapist at any given time because they're all enrolled in this company. And so we should explore telemedicine as one potential need for, as one potential solution to supply mental health resources when there's no physical counselor available on site. So that's my one response. I hope that answers the question. If not, chat in some clarifications that you need.
Thank you. Dr. Lakshmikant, you could put it back again if you have answered the question. So we'll go to the next question. It's actually one of the commonest problem probably at the resident doctor level. Now they're asking, what would you think the ideal workday duration to cause physician burnout, and how do we prevent it?
Yeah, that's a very important question. And if you go online and search for ACGME work hours, you will see that in the US, there are clear guidelines on the duration of shift lengths. For example, first-year postgraduate students in the US are not allowed to work more than a 16-hour stretch. But I think the optimal shift length is anywhere from 8 to 10 hours for physicians. Maximum 12 hours. And also there has to be adequate time in between shifts for recovery and rest. When I was in PGI, the first 6 months, we were called housies. And we used to do a 36-hour stretch, get 12 hours off, and then come back again for 36 hours. And we did that for 6 months continuously. That was brutal. But we got through it. But I would not recommend those kind of shifts for anybody.
Right. I have a question for you. Actually, if you look at the work pattern of Western and probably in India or in any other developing country, the doctor works for quite a lot of time. Either for financial or for the satisfaction, or for whatever you call it. So probably many of the institutions, when you ask them what to do, they say that the residents are supposed to be trained that way so that, they learn to work hard even later on. So do you think that, the level of physical work we do compared to, earlier days has come down because of, the modernization and, things like that. So you're not physically, we are not fit, or you think even the olden days, this thing has been the same from beginning, and we are only identifying that we are burning out.
No, I think a balance can be achieved. A balance can be achieved between humane work hours and optimal training. Because what happens when you start having work hours and like shift limits is that sometimes the trainees develop a shift mentality saying, okay, I'm going to stop taking care of this patient. I'll hand it over to you because I've reached the end of my shift. You don't want that to happen. And I've seen, I've personally experienced residents in the US where a patient was coding and they say, okay, my shift has ended, I'm leaving, I'm handing off to the other resident. So you don't want that kind of like lack of professional commitment to be promoted by shift hours. But I think in most cases, people are committed and engaged, and they will stay and continue their work as professionals. So I think we can achieve a balance without the crazy, inhumane patterns of work that we had in the past.
Very true, actually. There's Dr. Lewert, do you have time? So we just go on to the next question. So Dr. Lewert has asked a question that is, in the pandemic, health professional increased. The health personnel increased, stress, depression, bad mood, and suicidal tendencies. How many times should a doctor go to a psychologist, for example, an intensivist? Is there a scheduled, irrespective of whether, they have, they identify as depression or not, should they go to a psychologist irrespective of their state of mind?
That's a good question. That's a bit like getting your car serviced every 3 months or whatever, right? That's a good approach. I personally would support that, but I don't think it's happening in many organizations. And ultimately, the responsibility for servicing our mind lies with ourselves right now, and to some extent with our family members and colleagues. But if somebody were to create a program where everybody goes and sees a mental health professional just for a check-in, I think that would be a great program, and I would strongly support it. But right now, we're on our own, frankly.
May I just add on to that question that has just been asked? When you did mention about, as a, MOT for the mental health, especially at the resident doctor's level, there is a certain worry as to how confidential is this, how confidential is this report? That would it have a bearing on the next job hunt, or would it have a bearing on your career path, your visits to a mental health specialist, especially when you're in a training program? So is this a realistic worry amongst the resident doctors?
Yes, this fear of violation of confidentiality
Yes,
is an important reason why health professionals do not seek help.
Yes.
Because they feel that will become part of their record and will affect their career and their licensing and credentialing as well.
Yeah.
So many organizations have clearly stated that they have policies that mental health issues will not be considered a barrier to job searches and credentialing and licensing. So policies like that help, but leaders ultimately have to reassure people about confidentiality. So if you're a program director of a training program and a trainee comes to you with a concern about their own mental health and wellness, you have to hold that in strict confidence. You should avoid making a diagnosis about the trainee, and you should refer them to a certified mental health professional who will hold everything they talk about in confidence. And of course, people can also seek help from friends and family members, but they're not qualified or certified for mental health issues.
Yes, thank you. Thank you so much. There was another question that had come in probably in another box, but I did see it. Somebody did ask, is chronic fatigue syndrome, how different is it from burnout? Is it the same or is it different? I think there was a question mentioned about that as well.
Very different. I don't know anything about chronic fatigue syndrome, but it's a different entity.
Okay, there's another question they asked. On an average, how many patients do a pediatrician attend in the outpatient department in a day in the US? On an average, how many patients do a pediatrician attend in the outpatient department in a day? Probably you could say the average time taken per patient, or yeah.
Yeah, the expectation is that you see a patient every 10 to 15 minutes. Yeah, the expectation is, and a lot of physicians here are measured on their productivity, which also adds to the burnout because some are more efficient and some are less efficient. So it's almost like a factory atmosphere where you're supposed to process the patients very quickly and keep going through. And that slows you down. And because of that, what is happening here in the US, because pediatricians are supposed to see patients every 10 minutes or 15 minutes, they're supposed to complete their note, follow all the policies, like they have to check if the child's vaccination is complete, have you given the anticipatory guidance, blah, blah, blah. And everything is documented in the electronic medical record. So when the pediatrician goes into the office, they focus on the computer, not on the patient, because they're trying to document everything so that they don't get punished later on. And they're less interested in eye contact and compassion and listening to the patient. This happens to me also when I go to my own doctor. His entire focus is on the computer and he's documenting my cholesterol, my blood pressure, my A1C, and he's not interested in my emotional state or what I'm struggling with or whatever. It's unfortunate, and but we need to get better.
Understood. And Dr. Aaron has asked, as a recent phenomenon, resident doctors appear fragile in the work sphere as compared to some years ago, where they very cheerfully worked long hours. It's a similar question what I asked earlier, I think. Why do you think this is happening? Are we trying to be perfect, or isn't perfection actually required?
Yeah, there's a lot of literature on generational changes in trainees and how, there's generation, the millennials and the Gen Z, they have different attitudes. But yeah. I think this attitude that we old guys have, that the good old days, we were all tough and we sucked it up and we trained well and became excellent doctors. I think that's a myth in our own mind. I think we were probably as vulnerable and stressed as the current generation. We just don't remember it. We've probably buried the memory somewhere. But I think there are some generational changes, but I think we need to approach all trainees with the assumption that they're well-intentioned, hardworking, and they want to learn and do the right thing. Plus, remember, they're also highly proficient at technology, which many of the older doctors may not be. So they have other skills that we don't have. But let's not stereotype the younger generation. That's what
Yeah. What is is there any age of onset for this developing this burnout syndrome? As we become older, is it common, or it can develop at any age? Is the question.
No, burnout has been reported in medical students, nursing students, residents, consultants, and attendings. So it can occur at all ages. Yeah. But the tragedy is that if a consultant who's around the age of 40 or 50 develops burnout and is not able to do an excellent job at work, that's a big waste to the person and to the society. because they spent so many years training, gaining experience, and just when they're at the peak of their career, if you get burnt out, it's like losing a big treasure.
Yeah.
So that's the need. That's the reason we need to.
I think we are nearly ending the end of the 1 hour time. On behalf of everybody, I would now request Dr. Manoj to come in. And at least on my side, I would say a very big thank you. That was really wonderful, Dr. Gautam. Thank you very much. It was a pleasure listening. Over to Dr. Manoj.
Burnout.
Well, today's session was a true eye-opener for most of us. And as usual, we all continue to, enjoy more and more of Professor Gautam's talk. We truly enjoy today's session, sir, and look forward to hearing and learning from you more and more. Hopefully, when we host our physical conference, we will have you with us physically, or at least as an online virtual faculty when we host the grand final of this Learn from the Legend series, that is IAP NeoCon 2022 in March next year. So thank you so much, sir. It's beyond words. The gratitude is beyond words, especially the 11th hour call, and then you took the call and tried to save. It was a big, to be frank, it was a big embarrassment for us to cancel the session. And it was the reasons were probably, there was no other way had you not stepped in the last moment. So thank you so much, sir. Thank you so much.
Yeah, thank you everybody for joining today. I see many old friends in the audience, Dr. Padma Priya, Ganesh, many others. And thank you for the opportunity to teach. I love to teach, and I'm glad to help out anytime.
Thank you.
Take care, everybody.
Thank you.
Thank you, sir.
Bye.
Let me also thank the moderators for today, Dr. Debjani Gupta and Dr. Prakash A. Both of them have done a wonderful job, and it's really, the session was well moderated. Thank you so much, both of you.
Thank you.
Thank you. And good night. Thank you. Good night.
Good night. And finally, let me thank all of you, dear friends, for being with us. This is the 35th session we have since we started last year. Last June, we started with Professor Ola's talk in June 2020, and we continue to have these sessions. We will have sessions up to March next year, and the next session is going to be on 2nd of September, Thursday at 7:30 p.m. on follow-up of NICU graduates' role of primary care provider. So I would request all of you to kindly join us for the next session, and do continue to be with us. Thank you so much. Have a good day. Good night.
Good night.
Thank you.
Thank you.
Can we leave?
Yeah.
Okay.
Thank you. Thank you, Dr. Manoj. Thank you.
Thank you.
Thank you, Dr. Thank you, Dr. Devja Gupta. I hope she's there.
Yes, I'm there, and I will take my leave of both of you.
Okay,
Yes,
thank you.
Thank you so much.
Thank you. So nice being, moderating along with you. Thank you very much.
Thank you so much. We'll see more of you in the future, hopefully.
Hopefully. Fingers crossed. Yes.
Thank you. Thank you.
Bye-bye.
Bye-bye.